Hello, my name is David Gallegos, and I'm an ear, nose, and throat and head and neck surgeon at CHRISTUS Ear, Nose, and Throat. Today I'd like to talk about thyroid nodules, a very common situation that I see pretty much every day of the week. If you've been diagnosed with a thyroid nodule or there's concern, first thing I want you to do is take a big breath, and we'll get through this talk together. I was born here in New Mexico and spent quite a bit of time in lots of places around the United States and had the good fortune to go to the University of Tennessee for undergraduate, back to UNM for medical school, and very fortunate to attend the University of Iowa in Iowa City, one of the top ENT programs in the country. So a little bit of background on thyroid nodules. A palpable nodule, meaning a nodule you can feel with your hands, is present in just about 5% of women, about 1% of men. However, when we employ modern techniques of imaging, such as high-resolution ultrasound, you can pick up almost up to 70% of thyroid nodules in a randomly selected population. Here's the good news, though. The vast majority of those are benign. And I'll go through a little bit of the workup and how we figure out the next steps. The first thing, obviously, to do, because it'll be the first thing on your mind, is to rule out cancer. And we can generally reliably do that with a few easy and safe techniques. There are a few people around the world with some notable risk factors. Unfortunately, people who have been exposed to radiation. And I'm not talking about the kind of radiation that we get here in New Mexico from the high altitude in the sun, but generally large amounts of radiation, such as in close contact with a nuclear disaster. For instance, people in Chernobyl area have extremely high rates of thyroid cancer, or people in Japan, unfortunately. However, the general population, unless you've had head and neck radiation, such as was used maybe during the 40s and 50s for benign conditions, prior to knowing of the long-term risk factors of radiation, generally the scenario for being a benign thyroid nodule is higher. The populations at risk, as we mentioned, also increase with age, actually. So as you can see here on my graph, there is an increase in a fairly linear fashion of the number of people affected by thyroid nodules with age. You can also see the anatomy of where exactly the thyroid sits. It's a small gland that essentially sits at the base of the neck. So a little bit more of an in-depth view of anatomy. The gland itself is about 4 to 6 centimeters from top to bottom typically, and less than 2 centimeters thick. It's a very important part of a system called the endocrine system as a whole. It generally has a role in metabolism, but also development. It is centered at the base of the neck between the largest vessels, the carotid artery, and the internal jugular veins. It's outside of the chest, but close to the entry of the neck into the chest. And sometimes, for surgical procedures, we actually have to scoop it out of the top part of the chest. The bottom line is all palpable anomalies of the thyroid, or things that you can feel with your fingers, should be evaluated with an ultrasound. It's safe and easy to do. Another point is that not all lumps are nodules. And so we employ a technique of ultrasound, which is the use of reflecting sound waves off of structures, where you can tell different structures from another, different densities from another. And it's safe. There's absolutely no radiation involved. As you can see here on the slide, it's done while you're awake, without any pain whatsoever. I know this is a complicated graphic, but this represents the kind of thing that we can determine simply from an ultrasound. We can determine the risk of something almost to within a percentage point simply by imaging it. Sometimes that's not enough, but it helps us to determine which nodules deserve a biopsy and which can be observed simply with imaging. The size and the features are evaluated, such as the presence of very dense material called calcifications, or the margins of the nodule, whether it's very spherical, round, or whether it has a concerning infiltrative appearance. Also, with any thyroid nodule, we should get some lab work. This is namely a thyroid stimulating hormone. It lets us know the function of the gland. by determining the function of the gland, we can tell whether this thyroid nodule, again, is going to be benign, but might benefit from removal. And how we determine this is with a separate kind of scan called a radionuclide scan. And again, this is safe and easy to do. Generally speaking, thyroid nodules under 1 centimeter, or approximately the size of the tip of your pinky, don't require further workup with biopsy, but perhaps surveillance with ultrasound. I know this is a busy graphic as well. However, we, as head and neck surgeons, need to guide you through this process as safely and as smartly as possible. So we use a large amount of data that's been accrued over decades of research. And I would say the best resource is something called the American Thyroid Association. And they put out very detailed guidelines for not only practitioners of surgery and endocrinology, but also patient-related guides. This is just a graphic that I refer to, several times a week, just to make sure that I do the very best thing for your interests. Essentially what we do is determine a stratification or a level of risk. And the first step, again, is thyroid ultrasound. If indeed we feel like the risk is high enough, then we prepare you for a biopsy. And this is again done just really under local anesthesia, meaning you're not asleep, you feel very little discomfort, and it's done sometimes even in our office or at a radiology suite where they do these types of things all day, every day. In this procedure, cells are removed with a syringe via a small needle poke. The problem is that this is not always definitive, but it is an incredibly important step. On this little slide here with all these purple cells, this is characteristic of just one of the many outcomes. This is called papillary thyroid cancer, which is one of the most common thyroid cancers. It is typically not life-limiting or life-ending, but we do have to address it. In this middle row, you can see the different stratifications of what we glean from a biopsy result. And it might seem very confusing, but this is just another level of risk stratification. Because the last thing we want to do is take out a gland that doesn't need to be taken out. There are always risks with surgery. And so each step of the way, we're making sure it is just the right thing for you. When you come to see me or one of my partners who is highly trained in just this kind of surgery, we first devise a plan. We put together the history, the physical, the ultrasound findings, the biopsy findings, if performed, the lab values, and we discuss it all. We oftentimes will also consult with the endocrinologist, who is a specialist in all of the endocrine system. And we work very closely with many endocrinologists really all over New Mexico. So, options would first include ultrasound, lab testing, and in the last decade, we've actually had an additional level of testing, which is molecular testing. Not all biopsy samples need to be sent for this, and I'll tell you just which ones those are, which ones will benefit, and how it guides your therapy. Sometimes, when we've done all of these very safe and easy techniques, sometimes we still have to take out at least half of the gland to start with. And that helps determine if we need to take out more or if you're just fine, and we monitor lab work, we monitor ultrasound, but at least we have a firm answer. And again, that is always a discussion. And between me and my partners here at CHRISTUS, we've safely carried out hundreds of these over the last 2 years, fortunately. There are some excellent resources for patients that I would guide you to if indeed you feel you might have a thyroid nodule. The first step could be referring to the American Thyroid Association, discussion with your primary, or if you have an endocrinologist, or call and make an appointment. We're happy to guide you through the entire process. Thank you very much for your time.